Friends, welcome to my workplace at Ranaghat, West Bengal, India. This patient having retinitis pigmentosa has progressive granular degeneration. The other eye has dislocation of bag IOL complex. So, my plan in this eye is to do a small rhexis, implant a multi-piece intraocular lens in the sulcus, and do optic capture. Let us observe the surgery. By this time the main incision has been made, and this is a side port on the left side of the main incision. And now capsulorhexis. My plan is to do a rhexis of about 5 mm or little less, about 4.75 mm, so that optic capture becomes good. So here I made a tag, and in this case I had to go clockwise to do the rhexis. And here the rhexis was becoming very small, so I went little more peripherally and did this rhexis. Size of this rhexis is about 4.75 mm, little less than 5 mm. Hydrodissection and hydrodelineation done, and the nucleus is rotated, mobilized. Phaco is injected to fill up the anterior chamber, and now I am using this pre-chopper to divide the nucleus into pieces. This is first division, and this is another division, and now I come out. And now is the time to introduce the Phaco needle. The machine being used is Oakley Cataract 3. The Phaco needle goes in with its bevel down, and some anterior cortical lens matter is removed, and then the nucleus is emulsified easily. See how difficult it is to hold this nucleus. I tilted the nucleus and started from the inner edge. Ultrasonic energy used is very minimal, about 40%. Flow rate is 45 ml per minute, and vacuum is 450 mm of mercury. And here it is. The nucleus is managed. And now there is lot of cortical matter. I inject some visco and ask for coaxial irrigation aspiration. Coaxial irrigation will be faster in this case because there is lot of cortex, and this cortex is sticky. Sticky cortex is difficult to remove with Simcoe. A little bit of subincisional cortex can be removed by the Simcoe. Again some visco. And now I use the Simcoe to remove the subincisional cortex. This is a totally unedited recording, and you are not missing anything. The posterior capsule is polished a bit by Simcoe, and now my plan is to do hydropolish, where I will use the irrigating jet of fluid to polish the posterior capsule. Here it is. The irrigating cannula of bimanual IA is introduced, and the cannula is swept side to side, and the cells sticking to the posterior capsule get dislodged. So this is a safe way of polishing the posterior capsule. Now I fill up the capsular bag and the anterior chamber, and now my plan is to implant a multi-piece intraocular lens. For that I enlarge the main wound a bit, and here is sensor multi-piece intraocular lens. It goes like this. Now the center of the optic is pressed, and this cartridge is placed in the injector, and the intraocular lens is advanced. And now how to place the lens in the sulcus. I'll turn the cartridge clockwise little more. I'll turn the cartridge clockwise, and the haptic will come out. I will touch the iris and then go into the sulcus. And now some visco over the anterior surface of the lens. Take a Macpherson's forceps, hold the trailing haptic, and place the trailing haptic in the sulcus. Now I take a Sinskey hook and dial the lens, and the trailing haptic goes in the sulcus. And now this is optic capture. Press the optic on either side. In this case, the optic was pressed towards 7 o'clock and towards 1 o'clock, and the optic goes into the capsular bag, and I went behind the lens to remove the visco. Again pressed the optic to place it in the bag, in the capsular bag. We can see ovalization of the anterior capsule, which indicates that the optic is nicely captured. Now let us check. With the Sinskey hook, you can see that the anterocapsular rim is over the optic. So the optic is nicely captured by the small rhexis. So the haptic is in the sulcus, optic is in the bag, and the anterior capsular rhexis CCC in the anterior capsule has captured the optic. This is very stable. This, when we implant the lens in this way, the bag IOL complex will never drop in the vitreous cavity. This lens, this haptic, will get fibrosed at the sulcus, and this haptic will keep the bag in position. It will not let the bag drop. So this is a nice way of managing such cases when the other eye has dislocation of bag IOL complex. Now the visco which was there in the antechamber is nicely removed. The antechamber is nicely formed. The side port is closed. The integrity of all the wounds are checked, and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.